Muscular lesions in this area very often are related to sports lesions, and certainly when you think of adductor, yeah? Well, what do you expect? Your resisted adduction should be painful. And the patient has pain somewhere in the groin or somewhere in this area. No? But you also need a positive palpation. If the palpation of the adductor is negative, then your first idea is perhaps he has a pubis problem and not a contractile problem. So keep that in mind. Yeah? Could also be periostitis. We have two localizations. We can have a lesion at the musculotendinous junction, which can be frictioned, or we have a tenoperiosteal lesion, and here we have the two options, friction or infiltration. So this is the palpation and the friction of the tenoperiosteal localization. So you have to feel adductor and bone at the same time. Or the musculotendinous junction, and this is going to be kind of pinching technique. This is a very intensive technique for the therapist. Yeah? At the beginning, you're going to feel that in your thenar. Yeah? A psoas lesion. Your resisted hip flexion from the basic examination is painful. Yeah? And we are lucky if there is a psoas lesion, apparently just over there. And this is a spot we can easily palpate. But you have to visualize that again. Exactly in the corner between the inguinal ligament and the sartorius, in between. Yeah. And how can you palpate that? You ask the patient to lie in the Faber position. Flexion, abduction, external rotation. So, in this position. Yeah. Look at that. What a beautiful sartorius. Yeah? So where are you going to find the psoas? We're going to find the psoas over there. Just under the inguinal ligament, medial to the sartorius, in that corner. Voila. And you're going to friction over there. But this is a sensitive spot. So when we friction over there, you're going to friction with your fingers in a flat position. Yeah? The moment you do too much this, it's not going to be pleasant for the patient. And the patient is also positioned in half lying because remember the basic rules. A muscle belly, you friction from a shorter position. The rectus, well, let me come back to this image. It could also be a rectus lesion. Then not only resisted hip flexion is painful, but also resisted knee extension. And where do we find the rectus? Lateral to the sartorius, and we're going to friction that part. And therefore, we put the patient in this position, but now you're going to really hook your fingers lateral to the sartorius, and your friction is just going to pull towards you. Make sure you have short fingernails. If your fingernails are too long, you could damage some skin, and that's not the purpose. A sartorius lesion is very, 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 very rare. Yeah? You expect pain on resisted flexion and lateral rotation, but your first idea is going to be a fracture of spina iliaca anterior superior. And then flexion and lateral rotation are not only painful, the resisted test, but also weak. And remember the basics of orthopedic medicine, a resisted test which is painful and weak. One of the first ideas, this is a fracture, okay? Happens with young athletes, it's an avulsion fracture. Yeah? They have sudden pain on activity, running becomes impossible, walking is painful, and they limp. Yeah? So it's an, yeah, It's an image that we may not miss. And then the gluteals. Yeah, gluteus medius and his friends. Yeah. A selective lesion of those structures is very, very, very rare. But on resisted abduction, when you have pain on resisted abduction, your first idea is not gluteus medius. Your first idea is compression on an inert structure or on pain on resisted extension. That's not going to be a gluteus lesion over there. Huh? But compression on an inert structure. More specifically, bursitis. There are a number of bursae in this area, so exclude bursitis first. How can you do that? Diagnostic infiltration. Yeah? But you're going to see these infiltrations in the chapter on bursitis. And then iliotibial tract, of course, very popular among sports people. Mostly the lesion lies cranial from the greater trochanter, but you have to make a differential diagnosis with a gluteal or a bursitis trochanterica because, yeah, they lie in the same area. Yeah? And sometimes the differential diagnosis is not that easy. If the patient is a sportsman, your first idea is iliotibial tract. If the problem just came from the sky, so to speak, it started spontaneously, your first idea is a bursa. Yeah? But you can do some extra tests. For instance, you can do side flexion. It's going to be painful. But if you cross the leg and then you do a side flexion again, you're going to put more tension on the iliotibial tract. That could be more positive. But when you have doubts, do a test friction on the tractors. Do 5 minutes of diagnostic friction, then repeat the functional test, and then the patient is going to tell you if there's a difference, yes or no. If it's a bursitis, I guarantee you that after 5 minutes of deep friction, nothing changes. Nothing, really. So, work as structured as possible, step by step, and try to analyze those images step by step. It's not an exact science, huh? That's a pity. Yeah? But we work with human beings and clinical images, they could be variable. So, step by step. But I do that, honestly, I see that once in a while, and I have to do a diagnostic friction massage just to confirm my diagnosis. Yeah? So how do we do that? We do that with the patient inside lying with a flat thumb. Okay, but it's described in the next films. And then quadriceps and hamstrings, well, a muscle belly lesion of the hamstrings, a real nice muscle belly lesion, what is going to happen? The fibers along that lesion, automatically they go into spasm to protect that lesion. Spasm results in limitation of movement. In another film I talked about the tennis leg, acute muscle belly lesion of the gastrocnemius. You're going to have limitation of passive dorsiflexion because of the spasm. Well, when you have an acute hamstrings lesion, your straight leg raise, for instance, is going to be painful and limited. If you have a tenoperiosteal lesion, you don't have this muscle spasm, you don't have limitation. Yeah? Keep that in mind. Yeah? Okay, when you want to friction and palpate the tenoperiosteal part, you have contact on hamstrings and ischium at the same time. The side lying position is much easier for you as a therapist in comparison to the patient in supine lying. Really. Yeah. And then the position for muscle belly friction. So, perhaps it's time for a coffee. Let's have a look at the films.
The starting position, slight abduction and lateral rotation. The deep friction is a pinching technique with thumb and fingers, with the heel of the hand as a fulcrum. A large reserve of skin is taken in the lateral direction, then pressure is applied, and the active phase of the deep friction is a horizontal movement in a medial direction. Make sure the arm stays parallel to the leg. Starting position, slight abduction and lateral rotation. For a right adductor longus, we palpate in the cranial direction with the left middle finger until we feel the inferior edge of the pubic bone. The finger is then turned 45 degrees medially and now feels bone and tendon at the same time. It is reinforced by the other middle finger. The deep friction is executed normally. The muscle is in a fully relaxed position, prone lying, knees 90 degrees flexed. The deep friction is the normal execution with all fingers, covering a large area in order to have an optimal mobilization of all fibers. The active phase of the deep friction is a pressure towards the therapist. The patient lies on his side with the hips and the knees in 90 degrees flexion. The deep friction is executed normally with 2 or 3 fingers. They feel the ischium and the tendons at the same time. It is easier to work in close contact with the patient on a higher position treatment table. The patient adopts the half-lying position. Site of the lesion, below the inguinal ligament and medial to the Sartorius muscle. For a right psoas muscle, we use the right index and middle fingers, reinforced by the left middle and ring fingers. For the patient's comfort, it is essential to keep the fingers horizontal and to increase the pressure gradually. Make sure that during the deep friction you keep a deep contact. The patient sits with 90 degrees hip flexion. We find the tendon just lateral to the Sartorius muscle. For a right rectus femoris, the flexed fingers of the left hand, reinforced by the fingers of the other hand, grasp the tendon. The deep friction is a normal execution with an active phase towards the therapist. The treatment table is in the lower position. The patient lies on his side with a cushion between his knees. After having localized the lesion, the therapist takes a reserve of skin towards himself, then puts the thumb onto the lesion and reinforces it with the heel of the other hand. Both arms are extended. The deep friction is the normal execution, in which the active phase is a forward movement of the entire trunk. The patient's pelvis is stabilized by the therapist's thigh and fingers. Half lying on the couch. The affected thigh in slight abduction and lateral rotation. We palpate a painful spot in the origin of the adductor longus tendon. The needle is inserted just below the palpating finger and directed towards the lesion. The entire painful tenoperiosteal origin is infiltrated by a series of small withdrawals and reinsertions at slightly different points, after having felt tendinous resistance and contact with the bone.